all of you. Myself, Poonam Rohira from Sun Pharma. Under the aegis of Mumbai Hematology Group and Sun Pharma, a hearty welcome to all our delegates for the meeting on thalassemia advances in 2021. So now I request Professor Agarwal to take on from the proceedings. Thank you, sir.
Thank you so much, Dr. Poonam. I'll just share my screen. Okay, so good morning to one and all. Our guest speaker for the day is Dr. Maria Capellini from Italy. She's going to lecture on thalassemia advances in 2021. This webinar is brought to you by Mumbai Hematology Group. It is supported by Sun Pharma and managed by Mice Ideas. I'm indeed grateful to Team Sun Pharma, especially Mr. Arvind Suri, Mr. Kanchan Banerjee, and Dr. Poonam Rohira to extend help to Mumbai Hematology Group, not only for this webinar, but at multiple occasions in last 20 years. Whenever we needed support, they are there. And to do the academic activities and educational activities of Mumbai Hematology Group, Sun Pharma has been a very, very strong support. Mice Ideas, as usual, have been very ably managing these shows. I'm thankful to Mr. Rajesh, Kalpesh, and their team for flawless presentation of everything that goes on during these Saturday, Sunday academic sessions of MHG. Grateful to Executive Committee of Mumbai Hematology Group for giving this free hand to me. Of course, our guest speaker, Dr. Maria Capellini from Italy. Once again, she has been there whenever we have asked her to educate us. And I think the thalassemia care in this country owes a lot to her dedicated support and help in traveling to India, doing these webinars at very frequent intervals. Discussants of today's webinar, who are themselves very eminent pediatricians and adult hematologists caring for the thalassemics in this country, and all of you for sparing your Sunday morning. Over 450 delegates have registered, 300 from this country, 150 from all over the globe, especially from the neighboring Asian countries, and almost 1/3 of you are the fellows and trainees, and therefore young budding star in the field of hematology who are getting educated from the best of the faculty in the world. Our next weekend activities include a discussion on management of acquired aplastic anemia in 2021, and the guest speaker is Dr. Philip from Brazil. And on Sunday, we have our own Dr. Palanki Satya Dattatray from Hyderabad, who is going to tell us about immuno-oncology and immunotherapy of CD30 lymphomas. To introduce the discussants of the day, we have Dr. Rajiv Bansal, who is a consultant pediatrician at Santokba Durlabji Memorial Hospital, Jaipur. He has been a star campaigner of thalassemia, a torchbearer, and has been looking after the thalassemics in that part of the country for last 35 years. Dr. Prashant Hiwarkar from Mumbai. He is consultant pediatric hematologist, oncologist, and a bone marrow transplant specialist at the prestigious Bhai Jarbai Wadia Hospital for Children, and has been relentlessly working on this field of transplanting thalassemics. Dr. Purva Kanvinde is his colleague, again from Vijayawada Hospital for Children. She's consultant pediatric hemato-oncologist, and she's been managing these thalassemia children, also a part of the prenatal diagnosis and preventive program. Dr. Omkar Khankar, our colleague in Bombay Hospital, and also professor at the prestigious TN Medical College, BY Nair Charitable Hospital. He is a pediatric hematologist, oncologist, and once again taking care of these genetic disorders, thalassemia and sickle cell disease. Dr. Priyanka Agarwal does the same from faraway place in Varanasi. She's Assistant Professor, Division of Pediatric Hematology Oncology at the Institute of Medical Sciences at the prestigious Banaras Hindu University. And Priyanka, thank you very much for joining us at multiple occasions for these educational sessions. And Dr. Amit Jain, once again from Mumbai. He is Fellow Pediatric Hematology Oncology and a Junior Consultant at now a very, very important and very caring Institute for Thalassemics in Borivali, the MCGM, Comprehensive Thalassemia Care, Pediatric Hematology Oncology in the BMT Center. And they are doing a human service to the help of thalassemic children, again, preventive program, treatment, curing them, etc. Now it's my pleasure to introduce Dr. Maria Capellini herself. She doesn't require any introduction. Anybody who has to do anything with thalassemia, she's there all the time. I can never forget when she has traveled all the way to Mumbai and spent whole day at Bombay Hospital teaching us all the advances in thalassemia, listening to our young budding stars presenting cases to her and answering their difficulties. And after that, till today, we've had a series of webinars from her on thalassemia, sickle cell disease, and allied subjects. For the formal introduction, she is Professor of Internal Medicine, Department of Clinical Sciences and Community, University of Milan in Italy. For the last 20 years, she is a full Professor of Internal Medicine, Department of Clinical Sciences and Community Health, University of Milan in Italy. Since 1999, she has been the Chief of Thalassemia and Hemoglobinopathy Center in that city and in that country. She is scientific advisor for the most prestigious international body in the field of thalassemia, the TIFF, which has contributed so much to the cause of thalassemia, and she has contributed to their meetings regularly. She was instrumental in establishing the guidelines for the treatment of thalassemia published by TIFF, and these have been the guidelines which everyone in India reads and practices, whether these are medical people, whether these are patients, whether they are caregivers, etc. She's done extensive research in the field of hereditary disorders of red cells, especially thalassemia. She has been an invited speaker and chair for various prestigious meetings and events across the globe. It's not just Europe or US, but anywhere, any part of the world, and she has been there. She's president of European Federation of Internal Medicine. Our usual Sunday quiz for the postgraduates. This time, this quiz is related to diffuse large B-cell lymphoma. The idea of these quiz is just to sharpen your knowledge, because when you hear something and you have to pinpointedly pick up something wrong or something right, it sharpens your knowledge. So today we are going to give you 10 clues regarding diffuse large B-cell lymphoma. And as usual, only one statement is a wrong statement. Pick up the number of that statement and email it to, again as usual, mbagarwal1@gmail.com. And the winner will be fastest finger first, speedily answering the correct answer, and you get your prize. And here come the 10 sentences. At the top, I have given the email ID again. Out of these 10, one statement is wrong. If it is number 9, pick up that number and just email it on this email ID. First statement is, the ABC subtype has an inferior outcome versus the GCB subtype. 2, double expressor DLBCL do not have as bad a prognosis as double hit DLBCL. 3, double hit DLBCL accounts for about 4 to 8% of total load of DLBCL in clinical practice. 4, double hit lymphomas are often treated using dose-adjusted epoch rituximab protocol. 5, interim PET scan to assess the response to treatment is a standard of care. 6. Post-treatment surveillance PET scan is not a standard of care. 7. Addition of lenalidomide, bortezomib, venetoclax, or ibrutinib to R-CHOP did not add to cure. 8. Replacement of rituximab with obinutuzumab to CHOP did not add to cure. 9. Polatuzumab vedotin, which is an antibody drug conjugate, together with bendamustine rituximab, is an effective treatment for a relapsed DLBCL. And the last statement is, as of July 2021, CAR T cell therapy has been US FDA approved after 2 lines of therapy. So these are the 10 statements. 9 of these are correct. 1 is false. You pick up that false statement, look at that number, and that number you have to email to the email ID given at the top. And if you are the first one to give the correct answer, you will be the winner. After Dr. Maria Capellini's lecture, we will tell you who all were correct and who out of them was fastest finger fast and the winner. Okay, we have a guest to inaugurate our webinar today, and we are privileged to have presence of my friend, Dr. Lt.Col A.T.K. Rao. And once again, who from the field of pediatric hematology or thalassemia in this country does not know Dr. Lt.Col A.T.K. Rao? It's our proud privilege to have you, Dr. Rao, to inaugurate this webinar. Again, to introduce you formally, he's senior professor, head of the Department of Pediatrics and Pediatric Hemato-Oncology at SIMS, Bangalore. Colonel, Indian Army Medical Corps and faculty in pediatrics at Armed Forces Medical College. Former chairperson of the Pediatric Hemato-Oncology chapter of IAP. He is DM and FNB examiner for students appearing for pediatric hemato-oncology in India, adjunct faculty of medical law, National Law School, University of India, Bangalore, former dean, MVJ Medical College and Teaching Hospital, Bangalore, expert committee member of the joint ICAR task force on pesticides and cancer, chair, ICMR expert committee, multi-center national protocol for the management of childhood leukemia, executive board member of the pediatric oncology group of Eastern and Mediterranean countries. Well, Dr. Rao, I'm really proud and privileged to have your presence. I request you to inaugurate this webinar and give some words of wisdom to our trainees and fellows. Thank you so much. And now it's all over to Dr. Rao.
Good morning to all delegates. Many thanks to Dr. M.B. Agarwal and the team at MHB for giving me this really singular honor to be the chief guest at this webinar today, which features one of the true legends of clinical hematology, a teacher of teachers, a dedicated contributor to immense scientific thinking, whose work on thalassemia will be remembered for all times to come, the one and only Professor Maria Capellini. Welcome to the webinar, Professor. No one would be more eager to hear your talk today than I, an ardent fan of your work for the last 30 years or so. Dr. M.B. Agarwal is a hard taskmaster, you know. Unlike chief guests on other occasions, he said that the chief guests of the MHG have to earn their keep. And towards this, he asked me to say a few inspiring words to the youngsters in this audience who are yet to decide on taking up hematology as a as a subject of study in future? Well, what can I say? If despite the presence of these two legends of hematology in this webinar, Professor Kapilani and Professor MB Agarwal, you still need my inspiring words to entice you to join hematology, then I strongly suggest that you don't. You don't join hematology. This is not a job for the weak-kneed or for the lazy. If you want to do that, you could always join gastroenterology. It doesn't take much of brains or effort to put in a tube in any available orifice. Or better still, follow the advice of Sharon Murphy, the legendary pediatric oncologist, who once told me a few years ago, you can always relax after you are dead. We need strong men and women in hematology. Those who will work incredibly long hours and sleep few. Those who will multitask with the laboratory, the blood bank, and the ward simultaneously, while all the while thinking of giving that inevitable postgraduate lecture that somehow seems to worm its way every week into the timetables of all departments of the hospital, which includes pathology, internal medicine, pediatrics, OBG, surgery, orthopedics, ophthalmology, ENT, you name it, they want you to give lectures on hematology. And sometimes even in the kitchen department, they want you to come and talk to them about hematology. So all ye of uncertain faith and mind, do not enter hematology or do so at your own peril, for you shall surely be swamped by the red, white, and blood and the blues of the blood components as you sail on the plasma of life towards your destination. Always at risk of floundering against the prejudices of your less well-informed colleagues in other specialties, or the bias of the hospital administrator who often wonders why it is you alone who makes so much of fuss while caring so deeply about your patients. But if you finally cross these dangerous currents, you will sail into the harbor of tranquility, where you will find, first of all, very enlightened colleagues, because only the best of the best come to hematology. You find yourself the cutting edge of advancement and technology. I wonder if you know that 80% of all new drug formulations worldwide in the last decade has been in specialties related to blood and cancer. More importantly, outstanding cure rates. You all know that the prognosis of early pre-B ALL in children now has reached more than 95% in many centers. So think hard, really think hard whether you want to join hematology or not. If you've already joined hematology, it's too late to think now. It's tough out there, but trust me, after 30 years pursuing this subject, I've realized that it's really and totally worth it. There are no shortcuts in hematology, no deviations on the long winding road ahead. But I can assure you there's a great destination awaits you when you finally reach the end of your journey. So pull up your socks, look ahead, work hard. There are no shortcuts. Do your best. Hematology awaits you. Thank you very much.
Thank you, Colonel Dr. A.T.K. Rao, for those very, very inspiring words and a wonderful speech. Thank you for your kind words as well. You have been I'm very grateful to you. You have been very gracious in sparing your time, joining us today, early morning, giving these words of wisdom, which will be very, very important to the guys who have been listening to you today and probably even in time to come. So thank you so much.
Thank you, Professor Agarwal. Thank you so much for calling me today.
Thank you. I think Dr. Maria Capellini is going to join us in a while. So what we will do, we'll utilize this time in telling you the answer to the quiz and those who got the correct answers and who is the winner. Okay, we'll do that in this interim period. You can see my screen, right?
Yes, sir.
Yes.
Okay. So the quiz was related to DLBCL. We had given you 10 clues regarding DLBCL and asked you to pick up the false statement. And these were the statements. The ABC subtype has an inferior outcome is a correct statement. Double expressor DLBCL, which you pick up on immunohistopathology, is definitely a better disease than double hit DLBCL, which you pick up on fish. This is double expressor is present in about 25% of DLBCL as against double hit, which is present in a smaller number. And that small number is 4 to 8%. So all these three statements are correct. Double hit lymphomas are often treated using dose-adjusted epoch rituximab, which is a very aggressive protocol, and that is absolutely correct. Most of the people in the world will do this unless the patient is not fit to receive this particular protocol. CAR T therapy has been approved after 2 lines of therapy is a correct statement. There is no doubt that this is going to move forward and will be sooner or later available earlier and earlier, because it already has shown a long progression-free survival and potential of cure. Polatuzumab vedotin, which is an ADC, when linked with bendamustine and rituximab in a relapse setting, has been a very powerful regimen and has been approved for the first relapse. Obinutuzumab was considered to be a next generation anti-CD20 antibody and hence probably giving superior results than rituximab, and hence was tried in combination with CHOP against rituximab plus CHOP, but it could not show its superiority. It only added to the toxicity, more neutropenia, more infections, more sort of infusional toxicity, and hence has not been approved. It's a irony of the things that what was discussed and researched for almost a period of a decade, that if you add one of these products, the lenalidomide, bortezomib, or venetoclax, or ibrutinib to R-CHOP, you will increase the cure rates of DLBCL, but overall that has not happened, and there are various reasons for that, and this is not a forum to discuss that. When you finish your treatment and you follow up the patient, you follow them up clinically and you follow them up with minimum investigations, PET scan being done at a regular interval as a surveillance is not the standard of care, because it does not really add to any early diagnosis, or if you do that, it does not really add to the cures. So this has been not the standard of care, and that's a correct statement. So that leaves us with this fifth statement. Interim PET scan is the standard of care. This is a wrong statement. And this statement is wrong because in many lymphomas like Hodgkin's, etc., we do an interim PET scan to assess the response and accordingly escalate or de-escalate the treatment. But when it comes to DLBCL, doing an interim PET scan after 2 cycles or 3 cycles of R-CHOP, etc., has not really been very beneficial. And you have not been able to take a fruitful action, and hence it's not recommended. So the answer expected from you was 5, because that is a wrong statement. So now I will tell you about the winners, etc. So those who have given the correct answer 5 include Dr. Amit Khurana, Dr. Yoga Lakshmi, Dr. Noora Hewage, Dr. Krish Kannan, Dr. Virti Shah, Dr. Murlidharan, Dr. Naved Tamboli, Dr. Kaustubh Shekhar, and the winner today is the second time winner for the prize is Dr. Kamal Patel. Dr. Kamal Patel was already our winner a couple of weeks ago. He's from Kolkata, and Dr. Kamal Patel, once again, congratulations to you to be correct and the fastest finger first. So we will send you your prize. May I ask the organizers whether Dr. Capellini has joined? Pankati?
Yes, sir.
Okay.
Sir, Dr. Kapilani hasn't joined yet.
She hasn't joined, right?
No, sir.
Okay. I think you and me have already sent her a reminder, and yesterday itself she had said that she will be joining. So
Yes, sir.
we will wait for her. Meanwhile, okay, Dr. Rao, you want to educate us? Our chief guest. Words of wisdom can continue. You unmute yourself, Dr. Rao.
This has given me an opportunity to get connected to so many of the students. And Dr. Kapilini's loss is probably my gain. And I would just like to give you a small, a very interesting episode which happened to me when I was in the army and posted to a high altitude area. It's a very small thing which I usually tell my friends and my students. So I wonder if you'd listen to this. So I was posted as a medical officer before I did my specialty in a remote area in northeast India, that was in Arunachal Pradesh. And we were in a location which was at about 12,000 feet at height in different areas. Some parts of the cantonment was at 9,000, somewhere at 12, and we were at the place where my hospital was, my medical center was around 12,000. Of the whole area of the army there. It was a non-family station, so only during summer the families would come to meet them. And one evening I got a call from the boss saying that you better come over to my place in a hurry. So I went rushing there because of, in the army the boss is the boss. So we went running, and there I found his young 18-year-old and very, very beautiful daughter, who was started, I believe she had come in the morning from her college in Lucknow and come straight up to the hills, and she started behaving abnormally. And she was screaming and shouting and pulling her hair and trying to take off her clothes and what kind of thing. So anyway, I was a young medical officer there, and I was quite enjoying the show. And I kept trying to find out what was wrong with her. I examined her, couldn't find anything wrong. Maybe just a spleen taper. Anyway. So she was becoming worse, started becoming hypoxic, I would say. I don't know what exactly happened. So we asked for a helicopter to come in, and because the weather was so bad, we had to keep her for 6 to 8 hours. And finally, we took her by helicopter back to the base hospital, which was at sea level. And she became perfectly all right. And at that time, it was a little difficult for us to explain to everybody concerned why we had made so much of a fuss to take her to sea level and take her to the base hospital. And when we reached the hospital, she was fine and she was talking normally, and it was really embarrassing. These things happen in hematology. Please bear with us. It was embarrassing, and then I got a whole lot of letters from everybody saying that you can't keep asking for casualty evacuation all of a sudden. Anyway, so to put the matters at rest, she went back to her college in Lucknow. I went back to hide my head in shame because I had, probably overstepped my brief. And about 7 to 8 days later, I get this call from the pathologist, the base hospital, saying that you go and find out from your boss whether his and his wife's marriage was consanguineous. Now, I just asked him, why do you want me to? I'm not going back and meeting the old man again because he's going to throw me out of the division, probably out of the army. So he said, no, you go and find out. And I went and asked, and he said, yes, they were first cousins. And then this pathologist tells me that, buddy, you've got a problem on your hands, and this girl has sickle cell anemia. And then the whole thing came back, I was just a medical officer. The whole thing came back, and it fitted in beautifully. She had a little bit of anemia. She had a spleen tip palpable. She was behaving abnormally at high altitude, probably hypoxia induced. And she became perfectly all right when she came back to sea level. I don't know if any of the other hematologists have had an experience like this. And it becomes only time tells you what exactly was the diagnosis. And I believe, her mother was very distraught. And she said she's going to get married, and you've given me a diagnosis of sickle cell anemia. What should we do, doctor? And all that. So, I mean, I told her very frankly that, madam, don't ask for the horoscope, ask for the husband's HB electrophoresis. Make sure they are not the same kind of problem in both. So this is an interesting episode of hematology, which I would like to, I wanted to share with you. I wonder if you any of the other panelists have come across such interesting episodes. Dr. Rajiv Bansal, I'm sure, would have had many, many such. And I'm sure we can keep this thing going on with all our experiences until Dr. Maria joins us. And Professor Agarwal also, I'm sure, must be having a whole lot of interesting things. And so we would love to hear from you whether you had such episodes in hematology earlier.
Rajiv will tell us his experiences.
I can only share with the youngsters my experience of dealing with thalassemia for last so many years. There are two things which I've been seeing. One is my realization how in a resource limited setting, you can think of this child is taking your medications at a regular interval or not. Is he well chelated or not? I mean, serum ferritins and all of the investigations, yes, there's no doubt about that. They're very useful. But what late and in observing all those of rightly chelated, very well chelated, especially in a combination medication, you see their hands and feet. What is the pigmentation? And you keep on keeping that thing in your mind. So I have around 100 children who come to me on a regular basis. Every month or maybe 2 months, I see them. I make it a point that I see them on a regular basis and assess them in my mind other than what the ferritins are. And also ask them how good they're chelating themselves. But the keenest thing which I've observed is what the pigmentation, has the pigmentation gone off or not? And I was so proud of myself treating these children. When I see this, their hands are totally clean, much better than and more beautiful than my own hands. I have a child, girl who's around 35, 38 years of age. Such a beautiful girl in our childhood. What not she had. She literally died. We started with IV Desferal for her, gave her Calfor for a long period of time. Now, so well chelated. She recently married about a month, 2 months back. And I was seeing her. She had pigmentation. She's a very fair child, very fair girl right from the beginning. But I used to see her hands, the hands, and then I saw her zeal because she wanted to get married to a person, and I made her understand that you need to be chelating yourself properly, and I saw the changes. And then over a period of time, hands, patches to begin with, and now all patches are gone. Clean hands, clean forearms, and now that makes me aware. Yes, this child is regularly getting her chelated. We 3-star T2 to young hematology, I would say, keep on observing them clinically, gaining clues, keeping their earlier these subtle signs in your mind, and you'll be much better off treating them. Thank you, sir.
And we have another one from Colonel.
Sir, I just wanted to tell the youngster that be careful of these thalassemics who present late, who present after 18 months or 2 years of age. Invariably, they turn out to be either an intermediate or they turn out to be associated with some other disease like a sickle thal or HBD thal or HBE thal. Maybe you could be a little hesitant, or maybe you could withhold transfusions till you see when how these children progress, because many of these children would do well with hydroxyurea. I've had this personal experience for 30 or 40 cases where they presented very late. We withheld transfusion despite so many of the indications for that. But over a period of time, maybe 6 months or 1 year, these children did respond very well to hydroxyurea and became transfusion free. I'm not sure what the experience Rajiv has on this and the other panelists, but we do get a lot of mixed thals here in South India.
Yeah, I agree with you, sir. And especially they coming from Calcutta side, ethal along with is very, very common. The only thing is
we get sickles. We have pockets of sickle down in South India.
We do have sickle also, but the important thing is that, sir, Agarwal sir can correct me. If they got a huge splenomegaly, you need to transfuse them a little so that otherwise the huge spleen takes away and their hemoglobin doesn't come up at all. That's the biggest of the problem, especially if they come a little late to you. The second other important thing which I have been observing in our grown-up thalassemia who are not well chelated right from the beginning is some kind of problems in their feet, legs, and then swelling, and then I would say nodule formations in these patients with of thrombosis in these patients. I don't know why, what happens to them, and two or three, especially if they exert themselves a little extra. Sir can enlighten what could be the possible things happening with these patients.
Well, thank you, guys. We have information. We are going to have this webinar with Dr. Maria speaking to us at 6 p.m. today. Okay, we are going to have it at 6 p.m. today. So I'm not sure this kind of sudden change. So how many of you must be free? But all the audience, those who are free, please join us at 6. You will get the link from Kalpesh, and all the faculty over here, whoever is free, please join us at 6 p.m. And I have a request to Dr. Rao. I may not be free at 6 p.m. Are you free to conduct that webinar?
You're talking to me, sir?
I'm talking to you.
Yes, that wouldn't be a problem. I think that would be okay.
I'm absolutely grateful to you because I will try my best to log in, but I will be a little late and I don't want any problem to happen. You are a gem of a person. Thank you so much for accepting this last minute. So to the service provider, to the faculty here, to all the audience, we will have a webinar with Dr. Maria at 6 p.m. this evening, today evening, and Dr. A.T.K. Rao will conduct this. And the subject remains the same, speaker remains the same, everything else remains the same. I apologize to everybody for whatever happened, but she is there with us at 6 p.m. today.
Certainly, sir. It'll be a pleasure and honor to do the same, to conduct this and introduce Professor Capellini. So if you would be so kind, if you would just send over that slide where you introduced Professor Capellini.
I will forward you all the material. And I'll try my best to be with you all. And I may be a little here and there. I will be finally there, but I don't want to take any chances. So the request to you. And I will send you my slides. And
not a problem at all, sir. We'll certainly do it. I hope, Rajiv, you will be there with me.
Yeah, I'll be certainly be there. It'll be a pleasure with you.
Wonderful. Okay, and I hope other panelists also will be there because we need to make this into a good session. Despite Dr. M.B. Agarwal's absence, which they are very large shoes, which I don't think I can fill, but we'll try our best, sir, to do a good job.
Thank you. And Poonam, if you are free, please, 6 o'clock. And the whole team from Sun. You are muted, Poonam.